What is up, everyone? Welcome back to another episode of the Babbles Nonsense podcast. Today, we are shifting back to some healthcare talk to kind of keep it a little bit more light and different. But I wanted to pull from both sides of my world, and that being like a nurse and a provider, but also a patient at the same time, and talk about how medicine truly works. Because believe it or not, I actually have these conversations in my day-to-day life, more than I can even count. And it begs to wonder, like, why nobody's talking about this. And just know that I'm also not giving medical advice. This is just my perspective after 15 years in healthcare and after listening to countless patients, especially veterans, during their exams. Over and over, I hear the phrase, "No one is doing anything for me." And with my medical knowledge, it's mind-blowing sometimes to see the gap between what patients are experiencing and how the system functions. So today, we're going to break down how to communicate with providers, both from the patient perspective and the nursing perspective, how medicine is actually taught and practiced, and why our system is set up for quote-unquote sick care instead of true preventative care. So if this is something you're interested in, give it a listen. All right, guys. So thank you for staying if you stayed. I want to start first from the patient perspective, like when it comes to how frustration can build up and how we speak to providers and stuff like that, because I've been there myself. And honestly, I get where frustration builds. Because providers are trained in what's called a differential diagnosis. That means when you come in with a complaint, providers are building a list of possible diagnoses in their heads and working to narrow it down. So it's kind of like detective work in a way. You're kind of working backwards from so it's like, if you think about detective work and how they have evidence and then they have to come to the answer, it's kind of the same thing when you come in with symptoms, that's quote unquote evidence, and then you have to do testing to get to the true problem. But here's the key. The more specific and direct you are as the patient, the easier it is for your provider to get to the right test and treatments to help you a little bit better. And I know for me, because I do have medical knowledge, I understand this and grasp this. But when I talk to patients about it and talk about how patients really should advocate for themselves, as a provider myself, I do not get upset if a patient is Googling or using ChatGPT or whatever their symptoms to kind of help explain their symptoms, because maybe they're so vague they don't know how to explain them. So we can use an example like abdominal pain because it's so broad. Like if someone comes in with an abdominal pain, that could be so many different things, right? So if someone comes in and says, "My stomach hurts," we have to ask a dozen questions. Where is the pain? Is it your right upper quadrant? Or is it your right lower quadrant? Because depending on where your pain is, that can make a big difference, right? So if it's your right upper quadrant, I'm over here thinking your gallbladder or your liver. If it's your right lower quadrant, I'm now thinking, is this your appendix? Is it an ovarian cyst if you're a woman? Is it testicular torsion if you're a man? Could it be possibly an inguinal hernia with referred pain? So depending on where your pain is, makes someone narrow down their differential diagnosis. I'm hoping y'all are all staying with me here. And then it determines on what kind of testing you're going to get, right? So if you're telling me it's your right upper quadrant of your of your stomach, your abdomen, then I may want to order an ultrasound of your gallbladder, versus if it's your left lower, I may want to do, do we need a testicular ultrasound? Do we need a transvaginal ultrasound to rule out ovarian cyst versus testicular torsion? Do we need a CAT scan with IV versus oral contrast depending on your body weight? Because sometimes the smaller you are, IV contrast isn't enough to see some organs. You have to drink oral contrast. So there is a reason why providers ask certain questions. And when patients don't answer directly, or when they give sometimes too much history, sometimes that can make it harder. So we have two extremes of patients. We have the patient who says almost nothing, making the provider have to drag information out of them. Or you have the patient who starts with something like in 1990, and then finally 20 minutes later, they mention the real reason why they're there, and a provider may or may not have zoned out by then. And I don't mean that disrespectfully or any kind of rude, but neither one of the extremes of someone having to pull information out, because then now it's almost like pulling teeth to get the patient to even speak, or then you're having to like kind of hurry along the patient who's talking about he had this pain in 1990. And even though that may be important down the road with questions, that's not important. And I guess I'm maybe coming from an ER perspective, and I'm thinking like critical care, because when you're in the ER, you know, you're trained what will kill you first. That is what we are trained on, like obviously life-saving measures, because you're in an emergency room. But the takeaway is for patients to be clear, to be direct, and trust that your provider is asking certain questions for a reason. The questions they're asking are not random. They're helping them narrow down that list of possibilities in their brain. And I know if you don't have any medical knowledge, you probably didn't even know that, but I thought it, should obviously be shared, because miscommunication is one of the top causes of medical errors. The Joint Commission has cited communication failures as a leading cause in over 60% of sentinel events. And sentinel events are serious, unexpected outcomes in healthcare. That shows just how much clarity matters in patient-provider communications and their conversations. So, like I said, both extremes can become a problem, because if you're giving too much information and it's kind of overload for a provider, think about a conversation that you have with your friend. If they're giving you so many facts and so many details that you're having to go, wait, hold on, now I'm getting confused. You said this here, this there. It's the same with medicine and conversation. When we give too much, sometimes it becomes brain overload and you are kind of forgetting why they're there. And I don't mean that, again, I don't mean that disrespectfully, but think about, there was a quote one time and I can't remember, like, humans' attention spans are only so long. So when we drag out conversations, and I'm bad about it myself in my personal life, like I'll drag out conversations, long text messages, especially to men, where we know like they shut down after like 2 or 3 lines. And I do the same thing. Like if I'm scrolling on social media and I come across a post that's forever long, I'm like, I'm not even reading this. And I know that's awful, but we have been conditioned and trained for that quick, fast paced in our everyday life. And it kind of transcends into our jobs, and sometimes our jobs is healthcare. But again, this is just from my perspective. I'm not saying every provider is like this. I have like 13 years of critical care experience, and this is just what shaped my healthcare experience, because I first started in an ICU as a bedside nurse, which is critical care, and you have to learn and discern and learn. And then I went to emergency medicine for, I think, 11 years, and then I did trauma for a year before I transferred into like clinic work, where I saw that there was kind of a disconnect. But I saw it in the ER too, like when people would come in, for example, with chest pain, and you're trying to be like, okay, does the chest pain, does it radiate? Does it go anywhere? Does it go to your arm? Does it go to your back? Where is it? Is it on the left side? Is it on the right side? Does it hurt when you take a deep breath? Have you traveled recently? Do you have any history of coronary artery disease or heart attacks? Does your family have any history of these? These are specific questions to say, in my mind, to narrow down, could this be a heart attack? Is this musculoskeletal pain? Is this a pulmonary embolism? Those are the things I'm thinking. And I know sometimes, again, if you're not medical and you don't know this, then it does make it hard to understand why sometimes physicians or providers are being like trying to hurry you along in a story. Like, again, I'm telling you, a lot of the elderly population would come in and go, well, in 1999, I had chest pain that was on the right side, and I went to the doctor multiple times, went to the ER multiple times, had multiple cardiac casts, and they couldn't determine what was causing my chest pain. And even though that, again, could be important later, 1999 chest pain doesn't have anything to do with 2025 chest pain, unless you say everything that, like, if you answer everything I ask and then you say, well, you should also know in 1990, I had the same exact chest pain and I had a heart attack. That's very important, right? Like, that's factual. But if you're telling me they couldn't determine what caused your chest pain in 1999, and you go through a 10 to 15 minute story, and then the outcome is they didn't know what was going on, that's not going to help something in 2025. But I don't want to deter anyone from saying what they want to say to a provider. I'm just trying to give kind of perspective from a provider standpoint. Okay. And then let's go on and move to the nursing side, like the conversations from the nursing perspective. when you're speaking to a provider. So for me, I've been the nurse, I've been the provider. I'm still a nurse, I'm still a provider. And I worked in the ER for 11 years. One of the biggest lessons I learned from this was the shorter and more focused your report to a provider, the better, especially to specialties like surgeons. Providers get dozens of calls in a shift, and we have to remember that, especially if they're working 12, 13 hours, they're on call, and now they're working 24 hours. So a quick, clear summary gets attention quicker than a long, drawn-out explanation, will get it turned out. So for example, let's think about like a patient who fell and they're on blood thinners. So to me, a bad version of contacting a provider would be like, hi, sorry for calling, but Mr. So-and-so in room 2 fell in the kitchen at 2:32 p.m. 3 staff witnessed this. We believe he hit his head. I checked his MAR and he's on Eliquis, which I've known and found out is a blood thinner. I've contacted the family. They're very concerned. They're crying. The patient seems to be okay. I did check them neurologically and I don't find any neurological symptoms to be wrong at this time, but we did call EMS to send them to the ER. We just wanted to let you know that. Versus, hey, Mr. So-and-so fell. He hit his head. He's on Eliquis. We sent him to the ER and the family has been notified. So even though the first one, yes, you're telling everything, and it's important from a nursing perspective because in nursing, we see the patient and the family in the room as a whole versus when you come to the provider side, you're trying to make sure the patient's okay, right? And I'm not saying nursing staff is not doing that either, but then you have way more patients. You may, like as a nurse, you may have, 4 to 5 patients that you're taking care of for the day. And then as a provider, you may have 50 patients on your list to see versus your calls versus everything else, right? So the quicker you can get to because that's just a quick okay, thank you so much for notifying me. I will make sure to see this patient on my next rounds. And then you could give your orders, right? Like Q2 hour neuro checks, if the ER doesn't do a CAT scan, we need to do that. And then that kind of makes it a better. So I'm sure you can see the difference in those two communications from a nursing standpoint to a provider's. Both share the same facts. One will take maybe 2 or 3 minutes where the other takes one may take 90 seconds where the other takes 10 minutes. And as a nurse, don't ever apologize for doing your job. Like I've had nurses call me before and be like, I'm so sorry to contact you. Don't ever do that. You're doing your job. You just should not have to apologize for doing your job. But just remembering to give the critical details that they need to know is the most important part. Obviously, if you want to give more explanation, do that at the end. If you need to say all that other stuff because that's just your personality, say it at the end because you've already got the provider's attention. I guess what I'm saying is get the provider's attention and then say whatever you need to say. So if you need to say Mr. So-and-so fell, hit his head, he's on Eliquis, we sent him to the ER, family was notified. I just wanted you to know that this was witnessed by 3 people. We did, see it. We did check his MAR. He's on Eliquis, which is a blood thinner. You can say all that at the end because you've already got the provider's attention. Just say what you need to say to get the provider's attention. And that goes into the SBAR method, which is situation, background, assessment, and recommendation, is actually the gold standard for structured nurse-to-provider communication. Hospitals nationwide train on this because it improves outcomes and it reduces errors. Because again, I'm going to look it up really quick so I can just have the facts about how long does it take for people to lose interest in a conversation from non-biased sources, because I think it's seconds, which is crazy. I remember reading it and then I can't remember what it said. So let's see.
If you're a podcast host or someone wanting to be interviewed on podcasts as a guest, visit podmatch.com. Podmatch automatically connects ideal podcast guests and hosts together for interviews. We always say it works just like a dating app, but instead of connecting you for dates, it connects you for podcast interviews. Podmatch has connected over 85,000 guests and hosts together for interviews that listeners love, all while saving you countless hours of administrative work through built-in automations. If you're ready to level up your podcast interviews on either side of the mic, start today by visiting podmatch.com.
So it says from a 2023 study found that young adults could maintain optimal attention during a continuous task for an average of 76 seconds before losing focus. And that's become more recent because attention spans are influenced by digital technology. So that's why we live in this digital world. And if someone's attention span is gone in 76 seconds, again, we do our best to stay focused, especially in the careers that we choose, but that does not take away from statistics or, kind of human evolution and whatnot. But anyways, I want to also address why the system fails and why it's broken, so that just from the provider, if you're listening, y'all know this, and the patient, you may not know this. So here's where we're going to zoom out for a little bit. The reason patients often, in my opinion, feel unheard is because our system is not preventative. It's reactive. It's quote unquote sick care. Insurance companies usually are in control most of the time. And I don't know if patients know that. Like, your provider may want to order an MRI, for your back pain or something, but insurance requires what's called step therapy. And their step may be, first, you have to order an x-ray. If there's nothing on the x-ray, second, they have to go to 6 weeks of physical therapy. And then third, if they go to physical therapy and they're still having pain, then you can order the MRI before it gets approved. And I'll give you an example of this. I worked in a clinic, where we did spine pain management, and we had a patient that fell. It was acute injury, even on top of their chronic pain, but they fell at work, and they came in, not able to really lift or move one of their lower legs. I can't remember if it was right or left, but I wanted to order an MRI of the back because we did an x-ray in office and it didn't show anything. And an x-ray is going to show you certain things like a vertebral fracture, like a bone fracture. Sometimes it can show you if the discs are, narrowing, which is degenerative disc disease. It can't always show things like a herniated disc, spinal stenosis, spinal canal compression, nerve root ending compression. It can't show you those things. MRI is gold standard for that. So if an x-ray doesn't look like, if you're looking at the x-ray and you're looking at the patient and their symptoms and they're not matching, the next step would be to do an MRI. I'm not going to send someone to 6 weeks of physical therapy, not knowing what's going on in their back with an acute injury, because we can worsen it with manipulation and movements and stuff like that in physical therapy. So for this particular patient, I had to appeal because their insurance denied their MRI, I think 2 or 3 times. And appeals take a while, guys. And that's why it becomes cumbersome. But it's, obviously doing what's right for the patient. And it takes time because you're still in clinic, you're still seeing patients. You're then having to write this long appeal with medical literature to back up why you want to do this. Meanwhile, the insurance company is just doing their job. They're following this step-by-step algorithm, and it's usually someone with no medical knowledge until you appeal it. Some insurance is 2, some is 3, and then you can do what's called a peer-to-peer evaluation, where you actually get to speak to a provider, tell them what you've done, give the symptoms, tell them the x-ray was unremarkable, and this is why you don't want them to go to physical therapy prior to MRI, and then it gets approved, but that's weeks later. The patient's been sitting in pain, and they're mad at the provider because they feel like the provider's quote-unquote not doing anything. Meanwhile, behind the scenes, they're actually doing as much as they possibly can for this patient. And this isn't rare. According to the AMA, prior authorization requirements delay necessary care for 94%, guys, of physicians. And more than a third of physicians report that these delays have led to serious adverse events for patient care. So that's why, it's so frustrating as a provider, when you are medically trained, and I get it. There's always got to be checks and balances. I truly understand that, and I appreciate that in any healthcare where someone's like, well, I don't really feel this is necessary. But when you see that it's, literally, I'm not kidding, someone who graduated high school, got a job at an insurance company, has no medical training, and they are doing what they are trained to do, and that's to follow an algorithm. If they don't meet these requirements, we don't approve it. And there is a huge gap there because we're not preventing anything. Let's say this particular patient, I did not do the appeals. I did not do the peer-to-peer because it just took too much time. Let's say that. And let's say I was like, okay, fine, let's just send her to physical therapy. And she had a herniated disc, and then I made it worse by sending her to physical therapy. I just, as a provider, could not live with myself doing that. So of course I fought for this patient. And of course we got the MRI ordered. But at the end of the day, it's not always like that. it's not always that easy or simple because it's frustrating. And so your provider may be frustrated at situations like that and then have to come in the room and try to put on this, smile to see the next patient when they're super frustrated at a situation that has nothing to do with the new patient in the room. And again, I get it. People, when I have these conversations with friends and family members, they're like, yeah, but you chose that career. Yes, I did. But at the end of the day, we are all humans. And that's what I'm trying. We're not robots. We can't just turn off certain feelings, and we do trust me, guys, we do the best we can, but even your provider is going to have a bad day and be frustrated about patient care, or maybe they were just cussed out in the room before you, or maybe if you're working in an ER or ICU, maybe they just lost a patient that they coded for 2 or 3 hours and they're sad and they don't have time to decompress that. So I guess maybe the perspective I'm coming from is maybe show a little grace. Like, obviously, if they're not doing what's right for you in front of you, then obviously point that out. But if they are doing what's right in front of you and they're not doing what you expect of them, maybe you were expecting a little more hand holding or expecting a little bit more, I don't know if compassion is the right word here, because I feel like even when I've been in those headspaces, I still have compassion and I'm still doing what's right for my patient. I'm still listening. I may just not be as talkative or, as smiley. And I don't know the right word for that, but I hope that makes sense. And I'm hoping I'm making it make sense. But there's also, I want to move on to the next thing. There's also what's called the preventative care gap. And when the Affordable Care Act was passed during Obama's administration, preventative services like pap smears and mammograms were supposed to be covered at 100%. And while the test itself might be free, facilities still bill you for using the machine or for coming into the facility itself, which leaves the patient frustrated and distrustful of insurance, because it's like, no, preventative healthcare is supposed to be there to not deter someone from getting screenings. Because let's be honest, it's a lot cheaper to pay for a mammogram screening versus chemotherapy for never getting checked out. And that's where the irony is. Preventative care saves the money. And I'll give you an example. The CDC estimates that every $1 spent on childhood vaccines saves $13 in healthcare cost. Yet our system still prioritizes reacting to illnesses instead of investing in preventative care. We wait until you're sick, which that's a whole nother theory, right? What's that called? Conspiracy theory, where, Big Pharma owns a lot of things. They push out drugs, politicians are pushing out drugs. And you almost want to think why are politicians backing this? You have no medical training. You're saying all this stuff with no years in research, no years in medicine. And yet we listen because, we're taught to trust these people. And then it's like a cycle, nobody's getting healthier. Actually, America, I'm pretty sure, and I'll look up that statistic. Let me actually look up that. I think America is probably one of the sickest countries, maybe. Let me look that up. Where does America lie when it comes to, I'm going to put in quotes, sickness compared to other countries? Because other countries do it a lot differently. A lot of people most countries do allow people to have health care. And so it says that in many respects, the U.S. has worse outcomes than other high-income countries despite spending far more. And it says, that's too many charts. Let's see. Break it down, short paragraph. Sorry, guys. I should have actually looked this up prior to doing this podcast, but I was like, let me just look it up while we're here. All right, so compared to other wealthy nations, America is one of the quote-unquote sickest despite spending the most on healthcare. Chronic conditions like obesity, diabetes, and heart disease are far more common in America, and in America, our life expectancy is lower. The U.S. also has higher infant and maternal mortality and more deaths from conditions that could have been prevented with earlier healthcare. A big reason is that our system is built around quote-unquote sick care, treating illnesses once they they appear rather than preventing them from the beginning. Things like insurance barriers, high cost, and fragmented access make it harder to get earlier screenings or timely treatment, while social factors like income inequality and lifestyle risks add to the burden. In short, Americans pay more but get worse outcomes, making the U.S. stand out as an outlier in global health. So that is wild. That is wild. But I kind of knew that. I just didn't know statistically where it stood. But anyways, I just want to kind of break it down like this. If you're a patient, just remember, be clear, direct, and specific with your symptoms. And again, guys, just know that this is my perspective. This does not mean it's the end all be all or how all providers think or feel. And I trust that the providers are asking questions for a reason. And if you don't feel like they are, get another provider. Advocate for yourself. Do it respectfully. And if your provider isn't a good fit for you and you need someone who does a little bit more hand-holding versus being a little bit more direct, do that. Choose what's right for you. Don't forget, as a patient, you have a choice in your healthcare as well. The way I practice as a provider is that this is a collaborative agreement. Like, I want you to talk to me. I want my patients to say, hey, are you listening to me when I said this? I still don't feel good with this. I know we've tried this. Can we try this? Like, I don't mind that. I know some providers do. And if you need someone who collaborates with you and your current provider is not, then change providers. If you don't want the collaboration and you just want to trust your provider and you're like, I don't care if someone's direct with me. I know, they come highly recommended. I don't need the hand holding. Then choose that provider. Just remember, as the patient, you also have a choice in healthcare. Don't forget that. And I educate my patients this all the time. Don't forget that you also have a choice. Yes, us as providers, we are supposed to advocate for our patients, but don't forget that you can also advocate for yourself or your family members. If you're a nurse, remember, you don't need to apologize for doing your job. Deliver short, focused reports, and then you can add whatever you need to add once you get the provider's attention. Don't forget frameworks like SBAR to keep communication clean. And for all of us, we need to push for a healthcare system that prioritizes prevention, not just reacting once we're already sick. And that does come down to, unfortunately, politics. And I'm not going to get political on this podcast, maybe one day. But this year, I've actually paid more attention to politics than any years previous because I didn't realize how important it was. Maybe it's just because I'm getting older and things like healthcare really matter to me. Obviously, because I work in it, obviously, because I talk to patients on a daily basis about it. And I am very passionate about what I do and how I can help my patients. So just remember that sometimes that does come down to looking at policies in healthcare. I think they sometimes overpromise and underdeliver, but that's another topic for another day. We just have to remember at the end of the day, medicine is about humans helping humans. And the clearer we can communicate, the better chance we all have at real healing. And just remember, this is not to give any medical advice or what to say or what to do, because I want you to obviously communicate with your provider how you want to communicate. I'm just trying to give a little bit of tips and, tricks to maybe catch that attention and then say other things. I know we all have to learn this in our everyday life, but just remember at the end of the day, everyone's humans and, we're not Chat GPT, believe it or not. We don't know everything and we're all learning together. But thank you for tuning in to this week's episode. I hope it gave you a new perspective. If it did, obviously share it with someone who might need to hear it. And as always, this, again, is not medical advice, just one nurse practitioner's perspective from years on both sides of the stethoscope. Actually, 3 sides of the stethoscope, being the patient, being the provider, and being the nurse. But until next time, guys, bye.